advancing ophthalmology screening through telemedicine.
So I'm a resident specialist in Mater Dei, and my main interest is in medical retina, so that's one of the things I'll be talking about. So I'll be going through a few things, mainly about teleophthalmology, which is the new big thing in ophthalmology. Telemedicine has been around for quite a lot, and who recognizes it as the delivery of healthcare services from one place to another using digital methods, and where healthcare professionals can exchange digital health information and use it either to treat patients or actually to educate other medical healthcare professionals. Now, telemedicine has been around quite a lot. We do tend to think it's something very new, but it's not. In the early 1900s, doctors used to actually use the telephone to ask other doctors to listen to a patient's heartbeat. And there have been anecdotal evidence as well of people phoning the doctor and asking them to listen to coughs over the phone. Then in the 1970s, with the introduction of television, more access to radio, there started to be the development of a patient education via these methods. And then once the digital era came on, then we just ran with it. And now with the internet era, there has been a lot of information, and as previous colleagues have mentioned, misinformation. Now, ophthalmology is one of those branches of medicine which has an immense propensity for this kind of method. Visual images are extremely important, and they can be used to facilitate screening and diagnosis, treatment and management. And it has quite a vast amount of applications, including access to eye specialists for people living in remote areas, ophthalmic disease screening, diagnosis, monitoring, as well as learning. And all these were especially important during COVID. Now, why should we go for digital? Why should we go for teleophthalmology? There is an immense advantage in terms of cost effectiveness and increased access. The referral patterns are easier to follow. There is efficient use of specialist time and early detection of disease. The reason being, if there's a specialist who's assessing 50, 60 patients in clinic, it's one thing. That will take time, but a clinician can actually see many more patients using their data and then detect disease much earlier, while then only focusing on personal time with patients who actually need it. And there are different applications. We can use it either in a synchronous manner, where we get the patient in front of us via screen and talk to the patient, or which is more commonly used, an asynchronous manner, where we collect the data, assess it afterwards, and then contact the patient. Now, ophthalmology is one of those specialties where we do depend quite a lot on technology. We've got digital retinal cameras, which do an excellent job of giving us a splendid image of the retina. We have optical coherence tomography, which is one of the new things, one of the more important things, as it allows us to see a lot of in-depth information without actual having to give contrast to the patient. Visual field analyzers have been around for quite some time and allow us to identify and monitor scotomas. Mobile apps, they give us the opportunity to assess our visual acuity, to assess our color vision. And then there are the artificial intelligence algorithms, which are now coming into play in ophthalmology. So again, it started off mostly as a monitoring system for retinal disease, mainly diabetic retinopathy. But then, once we started off, we are using it for glaucoma, for neuro-ophthalmology, adnexal eye diseases, as well as strabismus. And I've put up some cases so I can show you a little bit how we're using teleophthalmology. So in this clinical example, this is one of my patients, a young lady, 30s, and she was diagnosed by the neurology team as having idiopathic intracranial hypertension. Now, how does the ophthalmologist come in? We're there to see papilledema by all means, but now we can actually use our instruments, or rather our imaging technologies, to take a map of the optic disc. We can image it, take a picture, as well as have the visual field. So instead of sending this patient back and the neurologist needs to monitor by taking lumbar punctures at every visit, we are now excluding, or rather reducing, the need for invasive things, and instead just monitoring via these imaging modalities. And so I can guide the neurologist and say, listen, this patient has improved after acetazolamide. The swelling has reduced. No need for a lumbar puncture. Or rather then, if there's another problem, we can involve our radiology colleagues and take their advice for stenting if the patient is not improving. These are a number of images captured during screening programs. And excuse me, as you can see, we've got different pictures of retinas of different patients, and the white circle indicates different abnormality in the retina. We've got a choroidal melasma, we've got scarring, we've got a pale optic disc, an epiretinal membrane, which doesn't show clearly here. We've got an early vein occlusion, and we've also got diabetic retinopathy. From these images, without seeing the patient, without knowing any history, I know I need to see these patients. They cannot be sent back to normal screening. And again, this is another example of OCT monitoring. Unlike the other case where I was monitoring the disc, now we're monitoring the macula. That mountain you see in visit 1 is fluid behind the retina. So the intraretinal fluid is not supposed to be there. We're treating it with intravitreal injections, and on the second visit we can see it's improved, and on the third visit I can see that it's completely back to normal. So that way I'm diagnosing, I'm monitoring, and treating. Now, why are we not simply focusing on implementation of the teleophthalmology? As in everything, and as my colleagues have mentioned before me, there are a number of difficulties. We need adequately trained staff. The initial investment is quite large, so not everyone has access to it. There are technological barriers. Even simply uploading all the data online has been a massive hurdle we still haven't overcome locally. And then there's the human factor. As humans, we don't like change. It's been mentioned already, we prefer things to have a status quo. We're comfortable, don't move things. Now, locally, we have actually applied the idea of teleophthalmology in the National Eye Screening Project for the Elderly, which was supported by the Ministry for Health and Active Aging. Basically, we are inviting people over 60, between 60 and 80 years of age, who have not made use of primary or tertiary healthcare settings in ophthalmology within the last 18 months. They are assessed by trained nursing professionals, and they have a visual acuity check, intraocular pressure, and fundal photos. All these results are inputted online, and the ophthalmologist will see them remotely. Patients are then informed of their results via letter or phone by our nurses, and patients who we feel should be reassessed are invited for an appointment within 4 weeks to be seen by a specialist. The results are quite limited in the sense that this is only a project which has been around for just over a year. We've seen over 3,000 patients, and 10% of those patients were actually identified as needing further assessment. So we've identified patients who have early onset glaucoma, we've seen patients with unrecognized diabetic retinopathy, and we have managed these patients accordingly. The problem with all these is that the patients are completely asymptomatic. And so, by screening, we pick them up before there actually was a problem in the patient's life. However, like anything, there are some cons. We have space and staff limitation. The IT systems could be better. And then, unfortunately, we have referral delay due to overloaded tertiary care. So, in conclusion, there is a great promise for our patients in terms of teleophthalmology, but although it has the potential to improve access to care, to decrease cost of care, and improve adherence to evidence-based procedures, we do have a lot of significant technological and human barriers to overcome. So fingers crossed, maybe in 10 years things will keep on improving as they have already done.